Good afternoon. Roger Demikowski, speaking for the Board of Urology. We'll want to welcome you to our next in our series of virtual town halls that we've been doing. Our last town hall had over 900 views, and we're hoping that this one will be as successful as possible. We're trying to time these town halls to sort of be in cadence with significant events and/or to address concerns and questions that people may have. Many of you have submitted questions which we'll address towards the latter half of the hour. Also, I'd like to stress that you can submit questions live to Charlie Hall, who is our administrator, technologic administrator, and we will also manage those as much as we can given our time constraints. So a lot of good things going on and we want to catch you up on. I want to welcome, we have a good crew. We have a representative group of our trustees and board staff. Lindsay Franklin, who runs our offices here, as well as Charlie Hall, who does all of our information technology. David Joseph from UAB is on the line. Isla Skinner from Stanford. Gary Lamack from UT Southwestern, Cheryl Lee from the Ohio State, and of course Martha Terrace from Medical College of Georgia. We will have several presentations, and one of which will be done by Brant Thrasher, who I neglected to mention, who's our executive president of the board, and so we'll be really happy to hear that as well. What we do is our agenda, if you could show the agenda, Lindsay, please. The first 25 minutes or so will be a series of presentations related to, again, just-in-time information related to lifelong learning, which I know is a big area of question and concern for a lot of you, especially with the tests coming up, and we're going to try to address some of those issues as we move forward with those presentations. And David will be talking a lot about lifelong learning, and then Brant will also be updating us quite a bit on activities of the American Board of Urology within the American Board of Medical Specialties, which of course is the main oversight body which the ABU works with on these issues. So we'll go ahead and begin our agenda. David Joseph will be speaking next on the lifelong learning process and also on a pilot for that process, potentially to may really change that process dramatically, which is under discussion right now with the American Board of Medical Specialists. So David.
Thank you, Roger. Lindsay, if you can put up my slides. What I plan to do is talk a little bit in the next few minutes about continuing certification and lifelong learning. Next slide. And I think it's important that everybody recognize what our goals are for continuing certification. And we have the responsibility to assure that the public receives the highest quality urologic care. And we really need to be doing this by promoting our diplomat competency. We want to also support a continuous learning process. And obviously we want to improve standards of urologic care. And we do much of this through activities you're already doing in practice and quality improvements. And while our focus is on the public, we want to be doing this with working with all of you in order to meet and maintain our present goals. And I think it's also important for you to all recognize that everyone on the board is a practicing urologist, and anything that we come up with as far as activities are activities that we hold ourselves to also. Next slide. So a common question is, where do I stand in the lifelong learning process? And I encourage everybody to frequent the Diplomat Portal within the ABU website. And this is just a representative view of where I stand. This is from a couple weeks ago. And what you're going to see in there is there's two levels, level 1 or level 2. I'm currently in level 1. And below that, you'll see the application process. And we call this our portfolio. So there's several activities within the application process that must be completed during level 1 cycle and level 2 cycle. And you'll see in the second column, that's a deadline. Those are when those activities are due. And the final column is a check mark whether you've completed that activity or not. So it's important to frequent this site, and it will be a ready source of information about where you stand. Next slide. What this shows is the difference between L1 and L2. And the major difference between the L2 cycle is the fact that during this process, you will need to complete your complication and mortality narratives. You're going to have to complete a 6-month practice log. And then obviously you have the lifelong learning knowledge assessment exam, which some of you are approaching now. Next slide. The first thing to remember is the knowledge assessment exam is not pass-fail. It's low stakes, meaning that what we're trying to do with this exam is identify gaps in your knowledge. And what we would do then is if you do fall below a knowledge threshold for a certain content area, is assign you to certain CME activities that will support your deficits. The current exam is going to be undertaken in October 16th and 22nd. And interestingly, we've had a lot of people calling the office asking us not to postpone the exam because they've actually used the downtime they had earlier in the year to study for the exam. But we know that it's difficult to obtain seats. And because of that, expanded dates have been obtained in November 1st and 30th, and December 1st and 15th for anyone who is not able to get a seat during October. There's also been a question of, as far as can I defer? And we realize that this is a unique year. And it's placed a lot of people in difficult times. And for anyone who does not feel comfortable going to the Pearson Center to take the exam because of health reasons, simply call the office and your exam portion of activities will be deferred until next year. And this is without penalty. And this includes those of you in your last year of the cycle. Next slide. The knowledge assessment exam is 90 questions this year. It's split between core activity and the module, 45 on each. As I mentioned, it is given in a Pearson VUE testing center. The exam is 4 hours long. We've never had someone who's not been able to complete the exam based on time. The modules we have are 4. The first is oncology, urinary diversion. Second one on stones, lap and robotics. Third, andrology, infertility, impotence and infection. And we've transitioned the 4th module that previously was female pelvic medicine and neurourology. We had a lot of diplomats tell us that we really don't have anything based on office-based practice. And in fact, the majority of our diplomats did fall within this group. So we've transitioned the 4th module to fit within that group of office-based practice. Now, we fully recognize that everyone doesn't fit perfectly into any one of these modules. We're just requesting that you select the module that you feel is going to fit your practice the best. And Isla Skinner is going to be talking shortly about these modules in a little more detail and how you can best prepare for them. Next slide. Well, given all that, we do recognize that we need to change. Currently, we have the low stakes exam once every 10 years. And we realize that this bolus learning event or bolus activity isn't the best way to learn continuously. And it's not consistent with our goals. It's also given in a high security Pearson VUE center. And particularly this year, we all recognize that this isn't the best environment. And we have technology to move away from that. We've heard from all of you from past town halls that this is very disruptive to your practice. In order to travel to a Pearson View Center, some of you have to travel miles, and it's just not the best way to do things. And it's also very stressful putting all of this in one period of time in 10 years. Next slide. So using all that as a foundation, we are interested in moving forward with our continuing urologic certification and changing some of our goals to provide a more of a continuous formative learning cycle. And this is not only better for learning, but it's also better for your retention of knowledge. We want to make sure that whatever we do is not disruptive to your clinical practice. And the way we envision it is you'll be given a specific period of time where you'll be able to complete your activity. We also want to integrate this into your own personal lifestyle, meaning that you do it on your own computer, and whether you do it in the office or whether you do it at home, it's done at the convenience of whatever works best for you. The one area that we're not going to change is we won't go back to a high stakes environment. It's going to continue to be low stakes, meaning that when we do identify knowledge deficits, we're going to supplement those with CME activities. Next slide. So what we are proposing, and I want to reinforce this is just a proposal. What we're proposing to the American Board of Medical Specialists is that we work on a continuous 5-year learning cycle. Years 1 and 3, we envision will be self-paced questions. This will be very similar to what all of you currently do when you're reviewing a self-assessment study program, except you'll be doing this on your own computer. It will continue to be in a modular design, so you select one of the modules you want. And the way it'll work is that you will have an immediate question, you answer it, and as soon as you answer it, you'll be taken to the response. You'll know what the correct answer is, what's incorrect. There'll be a paragraph talking about why it's correct or incorrect. And then you'll also have information regarding supplemental information that you can go to for further learning. The years 1 and 3, the item-based learning supports what your current knowledge is. And it also helps you retain memory as far as some of the important concepts that you're currently going through. We envision years 2 and 4 to be working through a journal and guidelines library that we're establishing with the AUA. And the idea here is to be able to allow you to incorporate current topics and current changes in urology that would best fit your practice. We envision that there would be a requirement of, say, 8 articles a year. 4 would be in core and 4 would be in your module, but you're not limited while in the library to select articles or guidelines from your module. You could select anything that you thought would help support your practice. Then year 5 is going to be a knowledge-based exam similar to what is currently done in year 10 with 90 questions. The major difference here is that it'll be done on your own computer and again in your own environment. We're no longer going to be maintaining this in the high stakes Pearson View environment. In addition, we have proposed that if you maintain a certain knowledge threshold and show that you surpass that threshold in years 1 through 4, that you would be exempt from this 5th year exam. And again, I want to reinforce that these are all of our proposals and none of it has been set yet. Next slide. So what we have done now is we have submitted this to the ABMS. In November, there'll be a formal presentation of our protocol with a fairly rapid ruling on whether we can move forward. If we do move forward, we plan to roll this out in the first quarter of 2021. It's going to be completely on a voluntary basis. we're going to be offering it to those individuals in years 6, 7, and 8 of the lifelong learning cycle. If you participate in this, you will be waiving your need, or we will waive your need to then undertake the 10-year point in time knowledge assessment. Unfortunately, because of the resources available, we need to cap this at 500 diplomats. So the way we envision it, once the letters go out, the first 500 that respond, that want to participate in the pilot, will be allowed to do so. And with that, I'll turn it back to Roger and we'll continue.
Thank you, David. David, we've had 2 live questions, and since they're pertinent, can you give us some idea or directions regarding CME supplements?
Yes. The way it goes is when your exam is reviewed, if your content, there's certain content areas that we look on each exam, so everyone's individualized. If you fall short on a certain content area, then we will assign you a CME activity within that content area. And there's a list of this that we've worked with the AUA. I don't have all of them in front of me. But based on the way you score in the exam, you may be assigned 1 to 3 activities. And I think Brant is going to show that on the screen shortly about how those are identified. So when we talk about CME activities, it's not one CME credit, but it's an activity. Now, we would send the diplomat recommendations or possibilities, but there's no reason that the diplomat can't return and say, I've seen this activity, this fits my knowledge deficit, I'd like to participate in this. They should send that request to the office and it certainly would be considered. I can't read these other questions fast enough.
Actually, David, why don't we hold the rest because the CME was the big one. We'll do the rest with the main questions. Next up on our presentations will be Brant Thrasher, our executive director, who will be presenting some updates again regarding ABU activities and activities within the ABMS of the ABU. Brant.
No, thank you very much, Roger, and thank you, David. What I'd like to do today is really just talk about a few changes that have come up and also give you an idea of sort of our new roadmap from ABMS, changes we were already considering, but now we actually have more direction as to how we actually pivot and change to make this a less burdensome task for you in our continuing certification. So next slide. First up, these are our trustees. You can see Dr. Demikowski is current president. Dr. Skinner is on the call, president-elect. Dr. Nelson, vice president. Gary Lamack, secretary-treasurer. And Dr. Joseph, immediate past president, LLL chair. So he will be chairing this whole pilot in our lifelong learning committee. We try very hard to make sure we have a diverse group of folks as trustees. They're all volunteer. They're from a variety of geographic diversities as well as specialties. And Dr. Bach here, you can see second one down on the right. Dr. Bach is actually a community representative, in other words, practicing in a LUGPA group in Kansas City. So we have tried very hard to keep that consistent and have representation from a multitude of folks in different practices, but they all have to be active in their practice. Next slide. Additionally, people ask often, what are your nominating organizations? How do I get into this? Well, 4 members come from the AUA and would be from that nominating slate, 3 from GU Surgeons, 2 from the American College of Surgeons, 1 member from AACU, 1 from SPU, and 1 from SAU. Next slide. People often ask, and even leadership in these groups ask, what's the difference between the AUA and the ABU? What I will tell you, if you click it one more time, is that we do have different what I would call goals, but we work collaboratively and hand in glove to make sure that we are working on your behalf. So I say it this way, we are a certifying body and they are basically a membership society. So they're covering urologists and healthcare providers. Our goals are relatively similar, but we certainly have differences in what we're doing in that we're maintaining standards of certification and they're helping us identify educational offerings to meet those standards. Next slide. We have made a number of changes based on the pandemic. It's put us into a bit of a tailspin in that since March 16th, we've all been working remotely from the office there in Charlottesville. We've also had to make some changes to the qualifying and certifying examination as well as LLL. The new date for qualifying exam, this was changed in April, went from July 2020 to January 13th and 14th. That will be done at secure centers. We do have seats for those folks. And I think all people that want to take that have actually registered, are in good standing. Certifying exam, we've recently changed from February. We were worried about a peak in influenza A, B, as well as COVID still being active. In February, we changed that to May 4th through the 8th. We have made a multitude of adjustments in that certifying examination to make sure you are in a very safe testing environment, but we still are wanting to deliver an equitable oral examination for everyone. So we've been working very closely with the hotel in the Dallas, the Hyatt, the Grand Hyatt there in Dallas at the airport. We do believe we'll be able to do that. We've had to go through a number of changes. You'll have to have a mask. We'll be offering PPE, socially distancing, even on the elevator. We'll make sure that we've done all we can to make it a safe environment. We've also received multiple additional dates for the lifelong learning examination that many of you are interested in. About 90% of folks are registered. David has already mentioned that you will have no penalty. That is, if you're a candidate and you're going to be doing certifying examination, it will not cut into your window of admissibility, which is 6 years. So we'll not count this against you. It's out of your control. The same thing with LLL. Even the folks that are taking it in their last year, your 9th year, it will be given variances to those folks that just do not feel safe doing the examination this year, and make sure you have an extra year to do so. Next slide. We do have a new certificate, retired status. It can be granted if you write into the board and request, say, my date of retirement will be October the 31st or 30th, and I plan to see no further patients at that time. You have to have an unrestricted medical license at the time and in good standing with the ABU. You will have no further necessary requirements. It will be honorary, so no further fees. You'll see that it will be posted on our site as well as the ABMS site. Next slide. This is our new roadmap. It's what actually we've been working off of now for over a year. In 1976, the first board, which was the American Board of Family Medicine, initiated what they called maintenance of certification. They recognized that initial certification and continued certification were two very different things, but giving someone a certificate and expecting them to do nothing further for another 30 years of practice was probably unheard of, needed to be changed. It didn't happen in any other industry where you had a public face or a public bearing. So there were a lot of concerns about giving out a certificate and doing nothing more. And most felt that CME was not enough. But with MOC, there was an awful lot of concern and pushback that there was a lack of transparency when this all occurred and came out. This business of having a high stakes examination was a concern, transparency about cost, et cetera, et cetera. And therefore, ABMS put together what's called the Vision Initiative Planning Committee. And this was in early 2018. 27 individuals were part of the main committee from a variety of stakeholders. And they reviewed current certification and made recommendations about changes to recommend to the board of directors of ABMS. Next slide. What I will tell you is this was an exhaustive committee number of meetings. We had 21 hours of public testimony. Over 100 diplomates in a variety of specialties were interviewed, providing feedback on continuing certification as it stood, which was MOC, as well as innovations, future challenges. And we wanted to hear about, or they wanted to hear about operations, finances, a consistent message of transparency and fund use. And additionally, what did the diplomates really want? Next slide. What we found is that the diplomates want, back please, the diplomates really wanted a program that helped them stay current, identify, in fact, 100% said, yes, I'd like to have something that helps me stay current, but in the scope of my own practice. Additionally, I would prefer not to take a point in time examination or a high stakes exam. I'd like to have learning that was focused and more formative and something that would allow me to fill in knowledge gaps that I might have, but not so burdensome. And they valued article-based and longitudinal assessment models that were digital in format and potentially, as we've proposed, given from your own computer at home. Next slide. One thing that we have been doing well is this idea of remediation, but another recommendation that came out was a reentry pathway. You might remember for folks, we had a reentry pathway, but not really. Our reentry pathway, if you expired or you tested out or timed out, was to repeat your residency, which was just not a tenable solution. So let's talk first about remediation. Next slide. This is what David Joseph was talking about. We do have an exam that's criterion reference, so you do have a pass point. Content experts come up with, this is what we believe that the average practicing urologist should know. If you end up with one standard error above, meaning you are marginal pass, you'll be assigned 1 CME. If you are 1 standard error below, 2 CMEs, 2 standard errors below, 3 CMEs. Now, these aren't randomly assigned. I will be sending out after I take a look at your test, and I'll say, send this out as a potential. You'll have 5 or 6 potential offerings, many of which can be done in webinars. It may be as easy as an AUA update, but we try to make sure that it is not burdening you. You don't have to go to the annual meeting to meet these CMEs. What we're trying to do there, though, is make sure we have a post-test for that CME that shows a closure of that knowledge gap of that weak area, and you have a full year to complete the CME. Next slide. So this shows you a little bit of what we're talking about in visual format. You can see that the folks that are above the line, the marginal pass line, and above that pass point are all clear passes. And then you can have 1 CME, 2 CME, or 3 CMEs, and that's basically within that knowledge threshold. Next slide. Next slide. As far as reentry, as I mentioned, that if you have a candidate that fails out, times out, your certificate expires or lapses, or you request conversion from retired status to get back in, then we now work with 3 companies, one based out of Nashville, one out of Lawrence, Kansas, and one that has offices in both Raleigh, North Carolina, as well as in Denver. And they can do a professional competency evaluation for us. That's very critical. I mean, if you think about it, someone who's been out 10 years and has been out of the whole process will be very different from someone who just popped out and is trying to get back in. So that evaluation then can lead to us saying, okay, we need a little further CME activity. Additionally, if reentry criteria are met, we may ask that you take a qualifying exam again or an LLL remediation module. And all other outstanding continuing certification activities have to be met. But we do have reentry criteria and about 4 folks that are in that process right now. Next slide. Additionally, as David has mentioned, they did the commission recommended that we change to a more longitudinal format with an alternative to a point-in-time examination. We changed that years ago. So as far as pass-fails goes, we were not doing that. However, I don't think people still love Pearson VUE. That's never been more evident than this year, where we had difficulties with seats, we had capacity issues, et cetera, et cetera. So we want to eliminate that. We're working very hard to do that. And I think Dr. Joseph gave you a taste of what we're going to be recommending. And we hope to roll that pilot out early next year. Next slide. What I will conclude with is that we want to continue to work for the benefit of the public and you to deliver a fair, transparent, and valuable certification process. Continuing certification will evolve into a more longitudinal and formative assessment. We're going to try to get rid of the business of Pearson VUE and having this standard format of going to a secure center. Continued collaboration with the AUA is very important to deliver educational products to fill knowledge gaps. And we continue to take your feedback from AUA section meetings, specialty society meetings, and these town halls to change appropriately and hopefully to help you in your quest to continue to stay up on the specialty. So thank you very much.
Thank you, Brant. Next up will be Isla Skinner, who will be discussing how to prepare for lifelong learning exams. Isla.
Thank you. So hopefully it's clear from Dr. Joseph's presentation that we're going to have a pilot for this new program. So for the time being, there will be a lot of you who still need to take the current knowledge assessment exam. And we've had lots of questions about what's on it and how to study for it. So the exam, as David talked about, is a core module, and then you choose one of 4 other modules to make up the exam. At least 30% of the tests come from 2 main sources. One is the guidelines that are on the AUA website that cover many, many different areas of urology. And if, for example, you pick an oncology module, you may want to go, or you should probably go look at the prostate cancer guidelines, bladder cancer guidelines, and so on. We also take many of the questions from the SASP from the last 5 years, and several people asked about examples of questions. That's a great place to look for them. And as you know, if you've used that resource, not only is the question there, but there's an explanation of why the correct answer is correct, and often a reference so that you can go look it up. So those two sources are the ones that we think that essentially everybody should look at before sitting for the exam. There are some other options. So there are questions, for example, in AUA updates in the back of each update chapter. There are questions in Campbell's Urology in the study section. Those are all good sources if you'd like to test yourself. There is a review course put on by the AUA every year, and that did go on already this year. It was a virtual course, and we're assuming that that will go on to be available. The pediatric and female pelvic medicine recertifications include the main core module from urology, so that still is put together the same way as it will be for anybody else taking the recertification. And then the specific specialty section is obviously specific to that subspecialty. So for pediatrics, Dr. Joseph mentioned that there is a pediatric review course sponsored by the Society of Pediatric Urology. And the AUA is apparently currently planning another review course for the next AUA meeting, which, you know, we don't know yet if that's going to be virtual or not, but that will be another option to get that information. For female pelvic medicine, there's not currently a specific review course, but the core modules and the guidelines do include a fair number of guidelines on topics that are very pertinent to female pelvic medicine. So that's our recommendation. I think it's pretty straightforward. The guidelines are a great resource because those are updated regularly. They contain the most up-to-date knowledge as sort of distilled down by experts in the field. I think that's a great place to start. Thank you.
Thank you, Isla. We'll now open up to what we have received in terms of questions submitted both by you previous to this and also currently. Not surprisingly, a large number of these relate to lifelong learning. And so David is going to take both the questions that were previously submitted as well as ones that have just been submitted and sort of try to amalgamate all of the responses to lifelong learning. And David, there seems to be some questions about lifelong learning and CUC as well. So maybe amalgamate those two in your comments, if you would, please.
Okay. We're just going through some of the questions we received ahead of time. And I think the elephant in the room relates to these that I'm going to combine. And it's, can we cancel the lifelong learning program? Can the board consider eliminating further testing and grandfather in individuals who have previously recertified successfully on multiple occasions? In addition, eliminating the lifelong learning program. So the short answer to all that is no, we can't and won't eliminate the lifelong learning program. And it's really based on several factors. You know, medical knowledge and clinical skills, while we don't necessarily want to believe it, do decline over time. And it's the older age group, and I put myself in that need the support of continuous learning and education in order to make sure that we're meeting the goals that we want to. Not unique to urologists, but individuals really can't assess accurately their own competence. So it's known that the more you think you know, probably the less you really do know. So it's another reason for continuing education. And probably most important, particularly for urology, is just the way medicine and treatment changes so rapidly in our discipline that in order to stay up with all those changes, you really need to have a process that supports continual education. So those are the primary reasons why we will continue our lifelong learning program. Question is, how has the program maintenance of certification changed since 2017 when I recertified? And what do I need to do in order to maintain certification? Well, there really hasn't been a great deal of changes since 2017. I mentioned what we envision in the future will be coming in the future. But in order to determine where you stand, it's probably best to just maintain some type of contact with your Diplomat Portal. This has been mentioned. Several questions are related again to what happens if I don't want to take the lifelong learning exam this year and what kind of changes can occur. We encourage you, if you do not feel comfortable taking the lifelong learning exam in the Pearson Center, to defer until next year. And you will not be penalized, as it's been mentioned. A question related to from the audience here is, how does continuing urologic certification affect members in pediatrics and female pelvic medicine? And it's an excellent question. At the present time, the changes that I presented are related to the general certificate holders. At this time, individuals who have specialty certificates are still held to a different standard. We do envision that will change in the future, but at the present time, we need to first make sure we're going to be successful with the direction we think we're going to go with the general certificate before we can make changes to the other certificates. So at the present time, members in female pelvic medicine and pediatric urology will continue on the 10-year point in time assessments that you do now. Another very good question comes up is, if this goes through, what about those individuals entering years 9 and 10 of the cycle? Unfortunately, we're limiting the individuals to start the pilot in 6, 7, and 8 because we needed to have a group of individuals that we could actually follow through on. We do recognize that there had to be some cutoff, and we selected those groups as providing the best information we could obtain from the pilot. Because once we proceed with the pilot, we're going to have to survey and determine whether our results are successful and whether we can continue to roll this out. And as far as what kind of examples, can you give us specific examples for the knowledge test to help us study? And I think Dr. Skinner mentioned that at least 30% of the exam does come from the self-assessment products, and that's your best representative of type of questions that you're going to see in the exam. So I think that completes most of those that I can see, and I'll turn it over and continue to look through any new questions that have been submitted.
Thank you, David. Next question will go for Brant. Brant, there's more questions about the oral review course and timing, and also oral boards. Can you just give everybody the snapshot of where we stand? You've already sort of done that, but.
Yeah, sure. I'm glad to, Roger. Yeah, we did have several questions, and one that just got added that I'll address. Let me just go through a few of these. I'll tell you that the status of the oral review course, the AUA and Dr. Johnson, both of those oral review courses, they've been notified of our change to May. They have not given us, and I doubt that they've posted it yet, what their new date will be. They generally will show or do their review course about 4 to 6 weeks prior to the oral examination. So my expectation would be sometime in the spring, but I don't know that for sure, but that they are very aware that we've made that change. Another question was, all conferences are off this year. No in-person CME is possible. Our state medicine board has lowered the requirement for CME and licensing. I think that what's being asked here is, are you doing something similar? Most of our CME offerings are not going to require in-person. You're not going to have to go anywhere to do it. So right now, you should still be able to meet any requirement for CME and not need to go in person for any of the CME offerings. Another question came up about retired status. There is someone who had requested, is it possible that I could, says I'm a retired certificate holder, I want to volunteer at a medical clinic, Do I have to take down my retired status certificate and I'm going to be seeing patients, but it won't be doing urologic work? That's a slippery slope for us. As we say before, if you're going to retire, that means seeing no further patients. It's very difficult for us to sit back and monitor. You might be seeing a urologic problem or a non-urologic problem, but that's not what the retired certificate is for. So if you plan or have plans to see patients any further, don't ask for a retired certificate. That's not for you. So I think that in a case like that, then you would have to go through a reentry process, as I mentioned previously, to get back in. Another question about foreign medical grads. And I think this pertains to someone that might have trained, for instance, in Canada that did not meet initial certification criteria. We do have an alternate pathway, and I'll let Dr. Skinner, when she answers some of her questions, she can actually address this. But that alternate pathway for someone, for instance, that had been a full professor for 7 years and working at an institution where they're working with residents, you say, why would that be? Originally, this was set up so it would be a surrogate, since we don't know what sort of training, we're not there to monitor that training during residency. It would be a surrogate to see how someone functions teaching residents, going through the didactics of the conferences, et cetera, et cetera. You then have to have a multitude of reference letters, peer review, as well as an application. And then what we would do is have a committee look that over, not Brand Thrasher, but a committee that would look that over and see if it meet criteria, and then potentially enter into our certification process, which would start with the qualifying examination. So that is a possibility for foreign medical grads, and that would answer the question of someone that had trained in Canada but not met the initial certification requirements. Next is a question that says, the case log and testing should be used in cases where there's a history of lawsuits, reporting of incidents in the data bank, questionable reports or credentials. The majority of applicants should be recertified with proof of CME alone, with the absence of the rest of this. Why can't we use that as a standard? That's not really a standard. We have to have everyone actually show or meet the same standard. It'd be very difficult for us to sit back and say, well, this person doesn't have this or that, but until we look at the logs, we really don't know. There's we identify a lot of problems with logs. People are overusing, misusing particular codes, procedures. Additionally, with that process, we have complication narratives that we request further information on. It'd be difficult for us to apply one standard for some folks and another standard for others. So there's one continuous standard for this. That's required, that's fair. So we unfortunately can't pick and choose. So that would be my answer to that question. And I think that covers all that I was asked, Roger, to address.
Thank you, Brent. Really well done. So the next question has to do with the person whose certificate is expiring in 2023, and the individual's not interested in recertifying but may change their mind. I realize that the official deadline for applications for recertifications has passed. How are exceptions made? Martha, will you take that, please?
Sure. Yeah, we can certainly grant you a variance, just as we discussed people that have health concerns and want to put things off. But someone who's missed the deadline or who has changed their mind about going to retired status or just letting their certificate expire, please send us a request for variance. That's a letter to us, and give the reason. Don't just say, I missed the deadline, I want a variance, but give us a reason. My practice is having a hard time hiring new urologists, and I may need to stay on, or my retirement's not as good since the pandemic. Give us a little bit more information so we know that you're making an educated decision there. But we'll work with you on that. We certainly want to help you out, but a request for variance is the way to go.
Thank you, Martha. Next is just to sort of drive home the messaging about study materials. There's a question about what are the ideal study materials for the FPMRS lifelong learning research, which is coming up in just a few weeks. Isla?
I think I'm gonna actually see if you or Gary could answer that more directly for the FPMRS, since there's not other than guidelines that refer to that, for example, the recurrent UTI guidelines or the
Gary?
other guidelines that are out there.
Sure. So just to recap, what's on the test, it's about 35 to 37% core urology, which includes infection, inflammation, trauma, radiation safety, stuff like that. And then the rest is FPMRS. With regard to what to study, I think I would just fall back on what's been said. If you study a lot of SASPs recently, you'll see a fair number of those questions. I think it's pretty standard the way we go about doing that. Guidelines also are good to study as well. So I think if you focus on those things and stay fairly recent in the last 5 to 10 years, you'll see at least a good portion of those questions on the exam.
Thank you, Gary. Next question is my certificate expires in February of 2024. I'd like to enter the new 5-year lifelong learning cycle presented in the town hall, in the prior town hall. By what date should I plan to take the first knowledge assessment? And is their certificate then renewed for 5 or 10 years? Cheryl, you want to take that?
Sure, thank you. I think this is an important question, and Dr. Joseph has addressed this in quite a bit of detail just in this town hall. But I think it's important to note that this lifelong learning pilot, which is what this diplomate is referring to, is being done for several reasons. Dr. Joseph did outline some of these, but one, we do need to meet requirements established by our governing body, the American Board of Medical Specialties, or ABMS, but we also importantly need to ensure that urology has that low stakes lifelong learning process that has that continuous informative learning approach. But this pilot is just that, a pilot. It still needs to be approved by a subcommittee of the ABMS. Various aspects of this pilot could change during that approval process. And if it gets approved this fall, which we certainly hope it will in the form we're presenting it, but if it does get approved, the ABU is going to then send very detailed instructions to all eligible diplomates, as mentioned, with upcoming certificate expirations. They're in that 6th, 7th, and 8th year of their cycles now. So that information is going to include a summary of the final pilot, how diplomates can participate, and importantly, all those deadlines for various knowledge assessments. And of course, it is going to be limited to those first 500 that do opt to participate. So I guess I would say more details to come for some of those specifics.
Thank you, Cheryl. The next question has to do with surveys indicating that urology is one of the medical specialties that has the greatest physician self-reported burnout. And then there's an explicit criticism of having this particular town hall on a Sunday afternoon because it doesn't align well with the concept of burnout. And in this context, could the ABU consider a weekday time for future activities such as this town hall? So I'm going to ask Martha to comment on something that she's been working a lot on, which is our social media presence and our ability to listen with social media. But I will tell you, we are all very concerned about the psychologic and general health status of our diplomates. When we had asked previously for timing, weekends seem to work better for most people. Weekdays are a little bit more problematic because people work, have day jobs, so to speak. And so then you're thrust on the evening. And again, that impinges upon what could be family time. So, but we want to hear and we want your guidance on when to do these, because we plan to continue these town halls for the time being, given the inability that we have to meet with you personally. So Martha, could you just summarize some of the great work you're doing with social media?
Thank you. Yeah, so absolutely, we're wide open to suggestions. Weekdays, as Roger said, if you have it in the evening that impinges on family time for the East Coast people, that's still in the middle of the workday for the West Coast people. If you have it in the evening for the West Coast people, that's past the bedtime for the East Coast people that have an early OR in the morning, in addition to the weekdays just being incredibly busy for all of us. So this was the most popular time, but we know it's a bad time for anybody. And that's why we're recording this. We have a recording of this, and all of our previous sessions are on YouTube. They're on all of your podcast vendors that you have, whatever phone you have, you can listen to these via podcast. and listen to them at your convenience while you're driving or some other time when it's not getting in the way of the rest of your life. We're very sensitive to this, and please make suggestions. We'd love to hear from you if you have any other ideas, but we follow us on social media. We're on YouTube, we're on Instagram, we're on Facebook, we're on Twitter, and we have updates when we have new podcasts and things out there, so that you can listen at your convenience. Thanks.
Thank you, Martha. Really well done. We have one final sort of global question, which I'm going to manage. We still have a few moments if anyone wants to submit any others, but while we're waiting, let me just answer this question. And so the question really is, why does the ABU do what it does in terms of quote unquote self-policing? Why can't the medical schools, residencies, and leaders do it all? And why is the ABU involved? And it gets to the whole thrust of what's going on with lifelong education. As Brent will tell you, the ABU is our board. It represents urology. It oversees urology, but it does so as part of a federated group of other boards that cover really everything in medicine. So every specialty is represented by a oversight board, and ours is the American Board of Urology. And the American Board of Urology is committed to patient safety and patient quality of care, which is really a critical mission that we have. And so I want to stress that we feel that that the board is functioning within the Federation of State Medical Board, Federation of other medical oversight boards, to accomplish and ascertain the quality of practice as people move through their life. And Brant made a very poignant point, and as did David. The fact is that as you get further out from training, there is some drop off. And so it is important that we continue doing this. So I would really like everyone to understand that we're not doing this to create unnecessarily duplication of work. We're doing this really to protect our patients, and it is a very important aspect of what we do. So we have one more question. I'm going to ask Dr. Lamack to answer this one. And it's related to delaying the certification exam due to concerns regarding the current health crisis. Gary?
Yeah, so as everyone knows, we did delay the certifying exam from February to May, as Brant mentioned, to try to enhance the safety of both our personnel, our examiners, and of course the folks who are coming in for the exam. And I think we've definitely reached some goals working with the hotel, and can safely do this. Having said all that, we still realize that it's a big concern for a lot of our folks who are going to be taking the exam. And so we have explored and continue to explore the possibility of a online examination process. There are a number of issues with delivering that exam, as you can imagine, both in terms of security, in terms of delivering the content in a way that we feel is appropriate. We can do the same type of exam that we can do face-to-face. I think it's certainly possible. I know other boards are examining this, and actually in the near future we'll be delivering these exams, and they'll go through some of these processes, and perhaps we can learn from that. So having said that, I want to assure people that we are exploring this. We are looking into it. We are hearing you, and we'll see where this lands us. But at the moment, we're still hoping for a May exam in Dallas. We are, and if we do go in that direction, I want to assure all of you that we are making the changes at the hotel to make sure that it will be a safe exam. It will be different than has been done in the past, to avoid people being close together in close quarters. And so a lot of safety protocols will be in place if we do go forward with that exam. But as soon as we have more information about the exam, if it does change, of course, we'll deliver that to you. Thank you.
Thank you, Gary. So I would really like to thank the panelists today. We've essentially used most of our hour. This will be available on YouTube, as Charlie Hall mentioned at the beginning of this, as we all mentioned at the beginning of this. We want to continue this tradition of doing town halls frequently. We are thinking about doing another town hall in the January timeframe, which would have been immediately preceding the obviously the February oral exams. We do think it's a good time to sort of remind people of what's going on and again how to prepare and sort of remind them of the specifics about the oral exams as well. But we want to hear from you. We do value your input, and we want to work with you. I want to stress that the board's staff in the office are just tremendous. They are really pride themselves on what is universally acknowledged as being outstanding service. They are excellent at returning calls and living up to their commitments. So I want to thank them. Brand has done an excellent job of standardizing workflow in the office and making it easier for you as diplomates to deal with all the issues surrounding your particular diploma and meeting deadlines and whatnot. So we again would like to hear from you. As Martha mentioned, we will be listening on social media, and we obviously welcome questions and calls. And I want to again thank everyone on the who's participated in the panel. It's been a great session, and I hope personally that you have enjoyed it as well. So I guess we will, at this point, since there are no further questions that have come forward, basically say thank you very much for your time, and have a great rest of your day. And thank you for giving us a bit of your time on a Sunday. Have a good day.